Welcome to the Spotlight edition of the Future of Medicine podcast. I'm your host, Dr. Craig Wright. Join me as I have conversations with fascinating medical experts as we discuss a variety of compelling topics. We aim to not only inform you, but to empower you, instilling confidence along your journey toward optimal health. This podcast is brought to you by Brentwood MD. Located just south of Nashville, Tennessee, Brentwood MD provides best-in-class concierge primary care. To learn more about our innovative approach to primary care, visit our website at brentwoodmd.com. On this Spotlight edition, I'm blessed to be joined by Dr. Brooke Eastham. Dr. Eastham has been a dermatologist with Nashville Skin since 2014, specializing in medical dermatology for all ages, as well as aesthetic procedures. She graduated summa cum laude from the University of Tennessee in Knoxville. She then earned her medical degree from the University of Tennessee Health Science Center in Memphis. She received several honors there, including the Faculty Medal and the Dr. Herschel P. Wall Exemplary Service Award. Dr. Eastham completed an internship in internal medicine and her dermatology residency at Harvard Medical School, with training at several prestigious hospitals. She has published peer-reviewed articles and presented at various conferences. She is a board-certified fellow for the American Academy of Dermatology. In this first part of our conversation, we cover the prevention and treatment of skin cancers. Next, we'll cover several prevalent skin conditions that now have innovative treatments available. We hope you enjoy. Brooke, thank you so much for joining me on this episode. As you and I were just kind of chatting off air, we have known each other for a while.
A very long time.
Which is exciting.
Maybe 20 years at this
point. I know.
Let's
try not to think about that. But it's fun. You know, you and I went to med school together, and that's where we met. And that's actually one of the reasons I really wanted to invite you on, is because I have known you since that first year of medical school, through the training, had some great experiences together, had some not so great experiences
4 a.m.
together.
rounds, not
rough.
So fun.
But that tells me I know who you are, what you're about.
Thank you.
And then when you went off to dermatology and then landed back in Tennessee and Nashville, I was super excited. So excited to have you on. And as you kind of introduce yourself to our audience, just tell me a little bit about what led you specifically through that medical journey into the field of dermatology.
Yeah, so I knew pretty early on I wanted to do dermatology. I think it's fascinating how you can look at the skin, and that's kind of your window into what's going on internally. So I think for me, the big draw was kind of, you've got things that are visible on the skin, and that can be a clue to what's going on inside. So kind of that multi-system disease, the more advanced medical derm was my big pull. And then, I think the variety is so expansive in derm. From a given day, I can treat 10 different conditions in all different age ranges, which is fun. And now, kind of like you've got, internal medicine, there's family practice. And now I kind of see whole families where it's like I see the grandparents, then I see the children, I see the grandchildren, and it's fun to see kind of the multi-generational derm.
Yeah.
It's great.
Well, and that's interesting to hear you say. How often do you feel like some skin conditions kind of run in the family? Like, do you see that maybe parents are kind of concerned about their history, and so they're like, hey, can you see my kid or whatnot?
Absolutely. We always think about moles and skin cancer and all of that, but something as basic as acne. When I've got a teenager that has really bad cystic acne, and we've tried several things, I look at mom or I look at dad and say, hey, what was it like for you? Mm-hmm. Did you have to go so far as Accutane? And if they say yes, or yes, and my two other children had it, well, then you're kind of going, that's probably the road we're going to take at some point. Yeah. And we can decide if that's right for this child. But the history plays a big role in something as basic as that. Yeah. And then skin cancer, is huge in terms of risk of melanoma and those sorts of things.
Yeah. Excellent transition, because that was the first thing I wanted to talk to you about. I think skin cancer it's obviously so important, and with sun exposure being such a prominent risk factor, it's something that we're all at risk for. Some maybe more than others, even depending on where they live. But as we kind of talk about skin cancer, even before we talk about the types, let's talk about the prevention, the protection that people can have. How do you recommend somebody kind of approach sun protection and skin cancer prevention?
Yeah, so I think, there's so many sunscreen options out there, and you have to find one that you're going to wear. You know, I can sit here and say 20% zinc is great. Not many people are going to wear that, right? It's pasty. It's hard to even wash off. I think zinc-based sunscreen is the best. It gives you protection right away. So that's what we call kind of a physical or mineral blocker. That's going to be in all of the baby sunscreens. All the big brands have them. But they make a lot of transparent zinc formulations now that can be used daily. They can go under makeup. So those are truly some of the best.
Gotcha.
It also protects against visible light. And so when you look at pigmentary disorders such as melasma, there's growing evidence that it's not just light that we have outside, the ultraviolet light, but visible light as well.
Okay.
So zinc or titanium dioxide protects against all of that. So I think, that's a kind of a superior ingredient, but it's also finding the one that you'll put on.
Yeah.
And so I find myself often recommending brands that are just very lightweight. They don't feel heavy. SPF factor, 30 is the absolute minimum. But it's interesting when you look at sunscreen studies, I think the amount is about 2 tablespoons applied to the face. When have you ever applied that much sunscreen? So when you look at the data, you have to kind of say, okay, well, if I put 2 tablespoons of SPF 30 on my face, I'm probably not going to get any better than that, but we don't do it.
Yeah.
So majority of dermatologists kind of say 50 and up is good.
Okay.
And then if you are, at the beach, at the pool, you want to be applying every 2 hours.
Gotcha.
It's not practical to apply every 2 hours throughout your workday.
Yeah.
That's not going to happen.
Yeah.
But if you are, in the water, you want to be reapplying.
Yeah. Interesting. So I was unaware they had transparent zinc formulas, and that's just as effective as the previous versions?
Yeah. It is.
Great. So SPS 50 you could wear less of volume-wise and get the protection.
There's not a great study out there to prove that, but yes,
Gotcha.
And in my own personal experience,
Gotcha.
I find that to be true.
And I know a lot of people when they think of sun, especially as we record this here at kind of the beginning of summer, and people looking forward to getting a tan, getting out by the pool and the beach. You can still get a tan with SPS 50,
you can
which I think is a common, that's a common kind of misconception is like the higher the SPF, the worse the tan.
Exactly.
That's not true.
It's really not true. I mean, we're preventing burn, we're preventing sunburn, and the SPF clothing is great. It's 95 degrees here in the summer.
Yeah.
So it's hard to wear long sleeves. I love to be outside. I'm outside all summer long. I play tennis. I'm trying to play golf. I'm not very good. But, I'm outdoors quite a bit. And I think that's important, for overall health and well-being. We just have to protect.
Yeah. Well, let's dive into the types of skin cancer. Yes. The most common types that you see and that you treat. And then as you kind of describe those to me, tell me a little bit about kind of like population risk, how many people are affected by these so that our listeners can be aware of what their just natural risk may be like.
Yeah. So, I mean, in general, kind of common sense, the lighter the skin type, the easier you're going to have a sunburn.
Yeah.
And those are patients. So your fair skin, red hair, that is kind of the highest risk for burns. And we see a lot of skin cancer in those types of patients. So skin type 1, our darker complected patients, even myself, I don't burn very much at all. So my risk is going to be less just because I have higher melanin, content. Also with African Americans, less risk, but it can still happen.
Mm-hmm. Brooke, that's a great point about skin type and even ethnicity and how that can be a risk. So the lighter the skin types, the higher the risk of cancer, or skin cancer. Tell me more about the specific types of skin cancer, and give me just a kind of a brief summary of what each skin type is, maybe which one may be most connected to sun exposure versus another.
Yeah, so, basic types of skin cancer, we'll start with basal cell carcinoma. Yeah. So basal cell carcinoma is by far the most common type of skin cancer. The good news is that these are very slow growing. They are not typically aggressive. So, it's not uncommon for us to get a new patient in the practice and they say, well, this spot's been there for 3 years and it's just kind of slowly getting bigger, or now it's started to bleed, or now it's painful. And the great thing about those is that they're localized, right? It's extremely rare for a basal cell to go to a lymph node.
Okay.
I have had one patient that's happened to, extremely rare though. And it's not something that we worry frequently with patients. The next type I would say is squamous cell carcinoma, and that one is a little bit more aggressive. With squamous cells, I kind of like to think of them in two broad categories. We have our basic squamous cells that, can pop up fairly quickly. They can be painful, but they're kind of just like the basal cells. They don't spread. They're just on the skin. We're not too worried about them.
Okay.
Head and neck squamous cell carcinoma can be a little bit different beast. And those are ones that they can, if not treated quickly, go to lymph nodes. They can be more than locally invasive. They can get into nodes and then can be pretty extensive treatment with those. You've got head and neck oncology involved, head and neck surgery, sometimes chemotherapy, immunotherapy, radiation, and I would say nowadays immunotherapy and radiation would be the mainstay kind of adjuvant treatment that we'll see sometimes with those, but those are rare. But I kind of give you that information to kind of understand that sometimes a squamous cell can be more aggressive than a melanoma, which is not something that we're really taught much in basic med school derm, and certainly not in the population.
But that's more specific to the head and neck.
Head and neck is where we typically see
Interesting.
that.
So same process, just a bad location.
Bad location. Yeah.
Is that just due to proximity to lymph nodes and the tissues being different there?
I think it's just a different beast. A lot of times these are developing in, the classic situation is an older man who's had a lot of actinic damage, so a lot of sun damage. And sometimes they've been left untreated. They're not caught. They're not diagnosed quickly.
Okay.
Makes sense. Early detection is key.
Okay.
Absolutely key.
Well, thanks for pointing that out because I know. Especially with basal cells being so common, squamous cells being less common, both typically not at risk for fast progression, aggressive nature, metastases to other organs, except the head and neck of the squamous cell. Let's talk about melanoma, because I know it has a little bit of a different character there. So tell me about it.
Yeah, so the good news is right now, I feel like the majority of melanomas are caught early. Yeah. We're all very aware of, our skin, at least our patient population. A lot of times they notice a small change and they're coming in, or their primary care doctor, such as yourself, would notice that something's off and we get patients in quickly. Even so much as hairdressers are finding them now, which is amazing, on the scalp. Hey, you've got something new. It's changing. So I think with melanoma, you've got, your different types. The most common that we see are superficial spreading type melanoma. There's also melanoma in situ, and that means that it's localized just on the surface of the skin.
Yeah.
The more nodular melanomas that go deeper, those are often ones that maybe are kind of neglected for a while. Kind of like, I have had this for 2 years and I just haven't wanted to come in and have it looked at.
Gotcha.
That's not the norm in our practice. I feel like we're most of the time seeing patients at an earlier stage. At the earlier stage, a lot of times we're just treating this with a local excision. So local numbing medication, it might be a bigger scar to get the margins clear, but we're not as much worried about lymph nodes. As you get into deeper melanomas, a lot of times we're sending to surgical oncology. They're doing lymph node testing along with that local excision. What's really interesting now is something we call Castle testing. Have you heard of that?
I have not, no.
So the Castle test is a genetic test that you can actually do on melanomas as well as the more aggressive squamous cell carcinomas. And it basically can put that... They look at the biopsy specimen and look at the genetics of the tumor itself. So it doesn't require any extra testing on the patient beyond the biopsy, but they look at the genetic profile of the tumor and they stratify it in terms of low risk of recurrence, low risk of spread to lymph nodes versus high risk. Okay. So when I get the pathology result on a melanoma that's, beyond superficial spreading, or beyond in situ, I'm going ahead and getting a Castle test a lot of the time. So even if it's a 0.3, a 0.4, we're looking at that test to say, hey, do we need to think about a lymph node or do we not? And it can be really helpful, especially for the more aggressive tumors. And we're doing that now with squamous cell as well. Wow. And that kind of gets you into forming that multi-specialty team of surgical oncology, pulling in medical oncology, somebody that specializes in melanoma treatment. And I think with that, we would, we're really better at catching things earlier with recurrence.
Yeah.
Or, we have immunotherapy. So if they do have a positive node, then you're having that discussion as well.
Okay.
So lots of treatment changes in the past 10 years.
Yeah. Now, is that
wonderful.
Castle testing, is that standard of care, or is that still kind of dermatology clinic or clinician dependent?
I would say it is still clinician dependent. It is. In our practice, it's standard of care.
Yeah.
We've all kind of adopted it. But if you were to go out into a more rural area, it might not be something that's being ordered.
Gotcha. Now, that's good to know. That seems like a really advanced diagnostic that really informs the treatment plan, maybe immediately, but also kind of the surveillance plan as well.
I think surveillance is is the big takeaway with that.
Yeah. So obviously with melanomas, early detection crucial. But even with the slower growing basals and squamous, the earlier you know, the better. Walk me through how an individual can kind of assess their own skin and what you recommend that they do and they look at, and how when should they be worried? What's something that they should see or feel or experience that kind of raises a red flag in your mind that they should come in and see you?
Yeah. I think kind of dermatology 101, they call it the ugly duckling rule. If all of a sudden you see something on your skin that looks very different than what you already have.
Yeah.
We have a lot of patients that will have tons of moles, and it's not proper care to biopsy everything. You're kind of looking at their mole pattern, and if all of a sudden they get one that is really dark, or they have had one for years and that border becomes irregular, it's increasing in size, and of course pain or bleeding, those are all warning signs. Basal cells can be a little bit harder to detect. Sometimes a basal cell just looks like a shiny pink patch on the skin. So superficial basal cells can just be this bright pink color. But the key is it's new and it doesn't go away.
Yeah.
It doesn't go away. The more kind of classic textbook basal cell might look like a pimple. I get that, I thought it was a bug bite. I thought it was a pimple, but it's been there for 3 months.
Gotcha.
And it's not going away.
Yeah.
And those are kind of key things. Squamous cells, when they present, they can be really painful, and they can come up quite fast. And so something that's developing rapidly, growing rapidly, pain, bleeding, those are always reasons to come in.
Gotcha. Question I have for you, and this is kind of from a physician's perspective, of how I can best care for my patient's skin. Because being a non-dermatologist, when I look at their skin, I'm kind of like, I feel like an ignorant bystander, just looking at like, okay, if nothing looks terrible, I'm going to think it's probably okay.
Yeah.
How do you recommend patients consider routine dermatology visits? Like, is that something that I should add to their care team at a certain age or at certain risk? Kind of how should I be thinking of that as a primary care doc?
It's a great question. And unfortunately, we don't have a set age that the task force has come out with that says this is the age that you start, like we have for cholesterol screening and all of those health screenings. I think really it's patient dependent. If you have a patient, I will say if they're 35 and up, it's probably time to at least get a baseline look. I think that's a reasonable age for you to kind of have that as like, hey, have you had your skin checked? But if you have a 25-year-old that has a lot of moles, they've got a family history of melanoma or family history of dysplastic nevi, which is just a fancy word for abnormal moles, those patients should probably be checked as well.
Gotcha.
My patient range for skin checks is quite broad. I might have 16-year-olds that have a strong family history. Mom brings them in to be checked every year. One of the benefits there is once a year they get their skin cancer prevention lecture from me. It's reiterating what Mom is saying. But so, to answer your question, it is quite a broad age range. And just looking at their skin and saying like, gosh, you've got a lot of moles. Or you've had a lot of sun damage. If you have a patient that is an avid golfer or fisherman and they've just had this chronic sun exposure, they should be checked.
Gotcha. Great advice.
And I think always look at a patient's back. I can't tell you how many melanomas I've found patients coming in for psoriasis or one bump and they're 65 and I just say I don't want a full skin exam, just let me look at your back, and you'll find a melanoma sometimes. So that's that thoroughness that it's always good to look.
That's great advice. Along with that, and this can be really from twofold, things you may use in your practice, but also things that might be accessible for the general population. But we live in kind of this AI world.
Exactly.
Are there any tools that I can just envision, I've never done this, but I can just envision somebody snapping a picture of their skin, asking ChatGPT, what is this?
Oh, I'm sure it happens all day long.
I'm sure it happens all day long.
All day long.
Are there any tools that you actually have some like trust in that either you use as a clinician or that you have seen patients use that you feel like, oh, there might actually be something here, or is it too early?
I think it's too early.
Yeah.
I think it's too early. I think, we're all going to adapt AI. Every month we're going to adapt it more and more.
Yeah.
But I don't think it's going to take the place of a clinical exam.
Yeah.
I just don't. And there's going to be people out there that disagree with me, but I just think, a clinical exam is always what's best. I think those maybe what they can be used for is a screening tool. Like how worried do I need to be about this?
Yeah.
But ultimately it needs to be checked.
Yeah.
And I think, a really difficult realm are seborrheic keratoses. How many times have you had a patient that's like, oh my gosh, this is so scary and dark, and it is totally benign.
Yeah.
And
It's like the only time I can be a hero.
Yeah.
It's because like
that is normal.
I think I could teach my child how to identify that. And so it's like, oh, you're worried. Guess what? You don't have to be.
You don't have to be. I know. So, but I think it could maybe be, a triage tool, but ultimately a clinical exam. And, and now they do have, and I'm not familiar with it because we don't use it in our practice, but they have almost like a tape test where you stick, a piece of, diagnostic adhesive on, you take it off, send it to the lab, and it's supposed to look at the genetics.
Yeah.
That's not going to take the place of the pathologist.
Yeah.
Especially when it comes to pigmented lesions.
Yeah.
And in fact, our pathology group, when they're looking at abnormal moles and certainly melanomas, they have two physicians that look at it. Because there's so much room for diagnostic error there that a thorough histologic exam is always important.
Yeah. Yeah, I'm sure I'll prove this statement to be wrong in 20 years, but I find it hard to believe that AI, maybe with a superficial assessment, would be able to tell you what the biopsy result is fully with confidence. I'm with you. I think maybe it'll help people screen so that they maybe come in to see you sooner at times. But hard to believe that it'd ever be, the hallmark of diagnostics.
Exactly.
So as we transition kind of away from skin cancer into just kind of some common skin conditions that can affect really all ages, one that I see in my practice from time to time is rosacea. Kind of walk me through what rosacea is, how patients can identify it, and then how it's treated.
Yeah, so rosacea can develop at any point in life, I will say. I mean, sometimes we'll see children with rosacea, but for the most part, it's hitting, patients in middle age, late 30s, 40s, and then up. It's an inflammatory condition of the skin, kind of in the acne category. But in layman's terms, it's more kind of small pimples or pustules without the blackheads and whiteheads. So the prominent presentation will be kind of malar region, so across the cheekbones, the nose, but sometimes what we call the glabella or even the chin can be affected as well. So we think of the inflammatory component where you get the raised bumps, but there's also the vascular component, the vasomotor component, and that's where we get the rosy red cheeks and the flushing. You can have both, or you can have one of the other. Okay. Typically with the inflammatory component, you also have the flushing. You rarely see just inflammatory, but some patients just have redness, broken capillaries, or what we call telangiectasia is kind of in the background. And then when they have a trigger, such as alcohol, stress, heat, sometimes even extreme cold temperatures, spicy foods, caffeine, blood can rush to the surface and they get kind of the rosy red complexion, which can be really, it sounds benign, but it can be very upsetting for patients because it can hit, in the middle of a work meeting, it can hit at a dinner party, and it can also feel uncomfortable. So in addition to appearance, the skin can be very sensitive and kind of have a burning sensation.
Gotcha. That, I think, is the version I see, more the vascular component. How is that treated?
Yes. So unfortunately, from a cream standpoint, we don't have a lot of topicals that can effectively treat that. There's one medication called Rofade that temporarily kind of clamps those vessels down, but it lasts about 8 hours. It's going to wear off, and some people do have rebound flushing. So when it wears off, it comes back with a vengeance.
Gotcha.
So things like Rofade are great for a dinner party, a presentation. You want to keep it down for a certain event.
Gotcha.
But I don't always recommend it on a daily basis.
Okay.
The best treatment is to have laser done.
Okay.
So you basically, there's a few devices that we'll use. In our office, we have a device called broadband light, or BBL for short. And it's basically using focused light energy to target those broken blood vessels. Typically takes a couple of treatments. So I usually say a series of 3 to 4. And it's not perfection, right? But it can decrease it substantially. You can still flush even if you don't have the vessels there at rest, but it's usually significantly less, much more manageable. There's kind of an older school laser called pulse dye light, or PDL, and that can be very effective. There's a little more downtime with that. You can have a decent bit of bruising, but it can be very helpful. Also IPL, which we don't have in our practice, but lots of options out there. Unfortunately, it's cosmetic, and insurance does not cover that.
It's good to know.
So so it is surprising. More of a cosmetic treatment.
Okay. Gotcha. And then the topicals have their place more with the inflammatory.
So,
Gotcha.
You can use a sulfur-based cleanser such as sodium sulfacetamide. That can be really helpful. Another component that we treat now is Demodex. So I'm sure you heard of Demodex mite. It sounds terrible. It sounds like you have an infestation, but we don't think of it that way.
Okay.
Demodex is just a mite that we can all have on our skin, but sometimes you have kind of an overgrowth of that, propensity of that around the follicles, and there's a medication called Soolantra, which is ivermectin. So it's topical ivermectin, and it can do a phenomenal job. We'll often have patients use Soolantra or topical ivermectin for several months at a time. It almost puts rosacea into remission. And then you just kind of use it as needed when you get a flare. So what that cream's doing, it's treating that Demodex component, and then it's also treating inflammation. So you get both aspects of it. Old school treatment was just to put patients on doxycycline. Put them on antibiotics. And we do that some still for kind of rescue, but we don't ever want our patients on oral antibiotics long term. It's more of a rescue medication at this point. Additionally, there's metronidazole. We've had that forever. Azelaic acid. We have a decent treatment armamentarium for rosacea. It's very treatable, but you do kind of have to learn that it's a chronic condition. And it can wax and wane, and I think that's, patients don't want to hear that. But it's the reality. But thankfully, we have lots of tools to treat.
Man, that's excellent. I'm so glad we got into these topics, because I think it'll be value to a patient listening, but that was super valuable to me as a provider. You listed some things that I was unaware of, so super helpful. Good. Thanks a lot. Let's shift from rosacea to another common condition for the population, but definitely for my members, is eczema or atopic dermatitis. So again, kind of walk me through really the presentation of that, which I think my mind always goes toward like young kids.
I know.
But I'm now seeing it really across the ages. You just kind of walk me through when someone should suspect it, and then how we should be certain of the diagnosis and then begin in the treatment.
So I think, you're right. Classically, we think of that textbook picture of a child with, rash in the creases of the arms, behind the legs, maybe around the face. But it's not always clear cut like that. And adults often present very atypically. So I see adults, sometimes presenting with just a diffuse red scaly rash, on the trunk, the extremities, but sometimes it can be circular patches on the legs. So that's a specific type called nummular eczema. So it means coin shape. That's often misdiagnosed as ringworm. We get that a lot, where patients will come in, they think they've got a fungal infection, but it's actually eczema. And it's just kind of an atypical variant. I think your biggest clue is the skin is dry and they are itching. So itch.
The itching.
And itch is the most debilitating part of eczema. And again, it's one of those things that kind of sounds like, oh, it's itchy, but it can really disrupt quality of life. When you have a patient that comes in with terrible rash, oftentimes they're not sleeping. They're more anxious because they're not getting proper rest. So it is a condition that it might seem benign, but it can be very disruptive to quality of life. mainstay of treatment a lot of times is moisturizing. It sounds so simple, but one key point of treatment is you have to restore the skin barrier.
Yeah.
So we see a ton of eczema, and I'm sure you do as well, in the cold, dry winter months when the air is, devoid of moisture. We've got the heat running, and that's when skin starts to itch. And, the old saying, it's the itch that rashes.
Yeah.
So sometimes it's the itch, the dry skin that starts, and then we start scratching, and it just perpetuates this cycle.
Gotcha.
But yeah, lots of treatment options for it at this point, if you'd like me to kind of...
Yeah, I'd love to, but I'll actually start with what you just mentioned with restoring the skin barrier.
Yep.
Any moisturizers you recommend
Absolutely.
is kind of a mainstay of treatment and prevention, I guess, in a way.
Yeah, so a lot of the major brands such as CeraVe, Cetaphil, Eucerin, they have moisturizing creams rather than lotions.
Okay.
So cream is going to do a better job. These creams are typically packed with ceramides, which are proteins that help restore the skin barrier. So I like the example of, our skin cells should be a tight brick wall. When we have eczema, they're loose. And when the bricks fall apart, all of our water and moisture seeps out. Things from the environment get under the surface to trigger itch and inflammation even more. So those barrier repair creams are pulling those skin cells back together and restoring the skin barrier, and that keeps moisture in and the environment out.
Great.
So they're very important and kind of integral to the plan. And that's kind of a big part of treatment, also prevention. A lot of times we can get patients, okay, if you can get on this routine, this is going to be a non-issue for you. You might have to use a topical steroid or a non-steroid anti-inflammatory cream every now and then, but if you can stay on top of it, a lot of times it's very manageable.
That's great. I think that's a great place to start. And then when it does kind of flare up or go beyond that, tell me kind of how we start treatment.
Yeah, so, we would always start treatment with the moisturizers. Oftentimes we'll use topical steroid, never in excess. There's a lot of hype now about steroid withdrawal, and, people are scared of topical steroids. It's good to think of those as a rescue. We can use them temporarily, but then if we find that we can't stop using them without flaring, we have several non-steroid anti-inflammatory creams that we can use that have various mechanisms of action. There's the phosphodiesterase inhibitors that kind of, you've probably heard of Zoryve or Eucrisa. Those can be really helpful. And now we have Opzelura, which is really nice. Great for facial eczema. Doesn't burn. It is important to kind of know the differences as a clinician. Some burn when used on the face and some don't. So that's like your topical, modalities of treatment, but sometimes that's not enough. And now we have medications that are injectable, so they're kind of in that biologic category. And those can work wonders and be life-changing. So you may have some patients on Dupixent or Adbry. Now we have Nimluvio and Ebglyss. So we have 4 that are FDA approved for both eczema as well as just itch. So sometimes you'll have patients that just itch. And they're scratching, but it's not really eczema per se, but the itch is really disruptive to quality of life. So
great.
Many options now, and thankfully they're very safe.
Yeah, well, and that's a great transition too, because I did want to ask you about biologics, because truthfully, like many of us, I stream television, and I feel like every ad I see is Dupixent or Tremfya or various treatments in these injectable space, and often it's for skin conditions. So, without maybe going into each specific one and the indications, just give me kind of a broad brush of what you do treat with biologics and when those should really be considered on a broad scale. I know it's a super broad question, but just how should they be kind of approached in treatment? Exactly.
So I think, like I was just saying with eczema, it's when topicals aren't working. And the patient says, look, this is really disruptive. I'm not sleeping. It's making it hard to focus in life. And then you're kind of saying, look, it's time. It's time to pull the trigger. And we've got the biologics in eczema. And then with psoriasis, I think a thing to really consider as well is, do you have joint pain? One of my questions for patients is, they might just have psoriasis on the scalp that's fairly manageable, but do you have arthritis? And psoriatic arthritis needs to be treated. And a lot of times we can pick a biologic that can treat both the joints and the skin. There's a lot of great data for many of those agents that can do both. And I feel like when I have a patient with the joint involvement, I'm much more apt to say, look, we need to do something. And we'll pull rheumatology in and kind of work as a team.
Gotcha. Would eczema and psoriasis be the top two conditions you treat with biologics, or are there other common ones that you see?
Those are by far the top two. There is another condition that is becoming more and more I shouldn't say well known, but people are beginning to know what it is that have it. They're able to get on Google and determine that they have something called hidradenitis. So hidradenitis suppurativa, which is can be a broad spectrum of presentations, but essentially it's a condition where you can get painful inflammatory nodules under the arm, under the breast, in the groin, the gluteal cleft, and they can be small and minor and treated topically, or they can be extremely severe, and these can develop abscesses and sinus tracts and really be incredibly painful. And now we have biologics to treat those. So we have 3 now that are FDA approved for hidradenitis, and they have a lot of overlap within psoriasis. So you've got Humira, Cosentyx, and now Bimzelx. And so we have 3 different options, and these are game changers. I mean, this is a condition that can really affect patients, and these can kind of shut it down.
Wow.
Yeah, it's exciting.
I'm glad you hit on that, because I'd just seen a commercial on TV, I think, for that, and I was like, if we're treating hidradenitis with biologics now, like, where's the end? What's the end?
It's
so it's great that
for these patients.
Yeah, I think that's a great thing as far as, to really think about in terms of their management is, in some cases, maybe it can replace topicals and give them much more sustained relief, which is truly life-changing.
Well, and I think, too, if you think of hidradenitis, the classic way to treat it was with antibiotics.
Yeah.
And I'm sure you're like me. I mean, I'm trying to prescribe less antibiotics because gut health is so important. You don't want to be on those for too long. And now we have more targeted therapy that's like getting to the root cause of the inflammatory pathway.
Yeah. Well, Brooke, thank you so much. I know our conversation's not over, but for my typical listening attention span, we'll wrap up kind of part 1, and we'll kind of rejoin here in a little bit to talk about some other stuff. So thanks for joining me.
Thank you for having me.
Thank you for listening to this conversation. I truly hope you found it useful. You can find out more about today's episode and discover additional resources at brentwoodmd.com. Be sure to check out all of our other content that we've created by searching Brentwood MD on LinkedIn, Facebook, YouTube, and Instagram. If our content has provided you with value, it would mean the world to us if you subscribe to the show and left a review. This helps us ensure that more people, just like you, can find our content so that they can begin optimizing their health. To learn more about our concierge services that we provide to our members, visit brentwoodmd.com. We'd love to meet you. This podcast was for general information only and does not constitute the practice of medicine or giving of medical advice, as no doctor-patient relationship has been formed. The content of this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Listeners should seek the advice of their own trusted medical professional.